Got it. Okay. Um, do you see like a blue screen from me?
Yep.
Okay. All right. Yeah. At my hospital, every conference starts with 10 minutes of technical difficulty. So already you guys are so far ahead of what I'm used to. Uh, so kudos. Just thanks for the opportunity to be a little bit involved in your group. It's really quite impressive what you have done and what you're doing. And I've been in the course of my career involved with a few different rare diseases where most of the progress has been really driven by family-founded organizations. And so it's amazing that you're doing it, and it's great. And any way that I could provide some small support, I'm happy to be part of it. But I'm delighted that you invited me today. Um, and certainly, this is the time to talk about respiratory viruses in the respiratory season. I always tell people that between October and February for pediatric pulmonologists is like being a tax accountant on April 13th. Um, and um, and I think in the past 6 or 7 days, we've heard from about half of the patients that we've ever seen calling us and telling us that things are happening out there. So this is our time, and it's good to talk a little bit about it. I just have a few slides and a few things I'm going to introduce, but I'm really happy to answer questions and see where the conversation goes. So um, um, there are so many of the fall winter viruses, and I've just brought out a few of the highlights as our technology for detecting viruses in a rapid fashion increases. We just keep finding new viruses, and many patients seem to have multiple viruses at the same time. And now we're all used to the idea of people sticking things up your nose and telling you you've got viruses up there. We've had some viral detection for a while, but in the past 5 or 6 years, it's really accelerated. And these are just a few. I'm just going to introduce the names of these big ones, what we see, some of how we approach it, and then that'll give us time to talk about whatever's on anyone's mind. RSV. Um, RSV sometimes seems like the reason that pediatrics exists as a field. It stands for respiratory syncytial virus. It comes out usually in the fall and winter. It's a real problem for small babies. It makes them wheeze. It gives them pneumonia. The smaller you are, the bigger a deal it is. There really isn't any effective actual treatment for babies who have RSV. They would have what we call supportive treatment. I'm sure you've heard that term before. That means if your oxygen is low, we give you oxygen. If the baby's having trouble feeding because she's breathing too fast, we put an IV in. But we don't have anything that makes the RSV go away. The effective prevention for RSV has sort of been the goal for pediatricians for longer than I've been practicing, and we finally have. We don't have a vaccine that's available for children yet. There is a vaccine you probably heard advertised on the radio and TV for adults who aren't my patients. But we finally have something effective that's what's called passive immunity, which are basically antibodies. So these are concentrated antibodies at RSV. It was approved last year. The name is Beyfortus, and there was such a national shortage that I only knew a few patients that were actually able to find it and get it. So there was a big excitement about it at all the pediatric societies, and then kind of like a big dud. This is going to be our first year where we believe is going to be readily available for most pediatric patients. And it's one dose of antibodies at the beginning of the RSV season that's supposed to last for the whole season. So that usually runs between like October to March. In past years, there was something called Synagis that maybe some people have had their children, it was offered on by their children. Yeah. So Synagis was also antibody to RSV, but it was it wasn't long lasting. So you needed a monthly injection. It was unfortunately extremely expensive, which meant that the insurance companies and the regulating societies all tried to limit its access. So every year they made it harder to get. If you weren't severely premature or had real problems, you couldn't get it. This is the first year that we're going to find out what the impact of widespread. I hope we're going to find out, and people are going to accept it, and they're going to get it for their children. What protecting large groups of young children are from RSV, what it will do, because it's available to everybody. You don't have to be premature. You don't have to have congenital heart disease or something else. You don't have to prove that you have a problem if you're under a year old during RSV season. RSV is really common. Almost all children get it by the age of 2. But the very small babies and children with other medical problems, like some of the children in your families, are the ones that are at the most at risk for severe disease, respiratory failure, pneumonia, mechanical ventilation, that sort of thing. So that's RSV. And when your baby's sick with RSV, they do throw every treatment at it, but at the situation, but we don't actually think that much of that actually works. So prevention is really the key. Now, when I was in training, we didn't have tests for human rhinovirus or enterovirus, and so most of our patients that were RSV negative, we pretended they didn't have any virus. And I was sort of taught in medical school that rhinovirus was annoying, gave you a runny nose, but that was the issue. That was it. Turns out now that we're testing everybody for it. So I work in Brooklyn, so I always refer to it as Brooklyn's favorite virus. Even right now in my hospital, at least half the children tested positive for it this week. And you hear different places will tell you, they call it ERV. You may have heard that. HRV. It's really a family of viruses. The viruses that cause common colds, but there's a lot of them, and they all test the same on that rapid test. That's why it seems like some families will tell me, my kid gets this every month. When does it stop? And that's because they're probably getting slightly different flavors of it, but it tests the same on the test. Some of those strains of ERV can make a small child quite sick. It causes lots of wheezing, respiratory distress, can cause pneumonia. I can have some kids been in the intensive care unit for days or even a week with it. And nobody gets out of the fall and winter without one of these, I think, most years. We don't have any specific antiviral treatment for it. We don't have any vaccine. We have symptomatic treatment, which I'll talk a little bit about. Symptomatic treatment in my mind is slightly different than supportive care. For some of the symptoms that you get, there are some treatments, but it's not satisfying to most people. And so this is just some examples of some severe rhinovirus pneumonia, child on oxygen. And if your child is vulnerable for other medical problems, you of course are more likely to have a severe rhinovirus infection. Influenza comes out every year. We hear a lot about it. I think one of the problems that I think I have with getting people to accept vaccination against influenza is that there's a tendency to call any illness that happens in the wintertime the flu. And therefore, if I give you, or I beg you to get a vaccine against influenza, and you have some yucky illness with fever and other symptoms, you're going to tell me it didn't work and I'm not doing that again. But influenza is a specific set of viruses. They come out every year. They're different every year. So the vaccine we gave you last year probably isn't going to work against this one. There are antivirals against it. You've heard of Tamiflu is the major one. And they work okay if you started in like the very first day of illness, which usually by the time you realize you're sick, your child is sick, you're not on the first or second day of illness. And every year there are quite a few people who get extremely sick, wind up in the hospital, and some people who die from influenza. So we really feel very strongly that that vaccination is important. Even in the years that the flu vaccine does not prevent as much influenza as we would like, it really does prevent death from influenza pretty well. And so we really feel like of all the viruses we have, this is the one we actually have a vaccine for. So we really try hard to get all of our children and their parents and their siblings vaccinated. And then human metapneumovirus is one of the viruses that you don't hear about until your child gets it. But it's another one that's pretty common in the fall and winter time. And it gives you pneumonia. And if you have immune system problems or you have asthma, it could be much worse. Again, we don't have specific treatment for that. So we don't have a vaccine for it. We have symptomatic treatment only. So these are just the list is much longer, but these are the big ones. These are the ones we see the most of. And you know, as I was like throwing some slides together, I remembered that I had done a family education day on infection control for cystic fibrosis families in 2007, just a long time ago. And I looked at that talk and I saw that there was a lot of talk in there about hand washing and appropriate ways to sneeze and wearing masks and all those things that I started to like, you know, this was all like news to most people then. I really hope that in the past couple of years, we now understand the importance of hand hygiene, the importance of staying home if you're not well and not spreading it, and that, you know, that in the right situation, mask wearing can really, it may not protect you from everything, but if you're sick, it can definitely protect the people around you. So this slide is just for my nostalgia on that. And so I mentioned the word wheezing a bunch of times, and most people hear this eventually. Wheezing is air whistling through your breathing tubes that are more narrow than they're supposed to be. You don't whistle when your mouth is wide open, and your lung is really a collection of tubes, big ones that connect to little ones. And we're talking about two main things. There's a bunch of stuff, but the two main things that we deal with, particularly this time of year, is bronchiolitis. Bronchiolitis, which is what RSV does to little babies, is infection of the tiny breathing tubes, the smallest breathing tubes in the smallest patients. They get full of virus, full of dead cells. Air whistles and wheezes when it goes through those breathing tubes, but our medicine directed at wheezing does not have any impact. Very little helps when you have bronchiolitis, but time. And then asthma, or what some people call airway reactivity being the process that underlies asthma, is when there's irritation of the lungs causing a constriction of the muscles around the breathing tubes, the swelling of the lining of the breathing tubes, and that leads to trouble moving air through them, and then the wheezing sound. And so we have albuterol. It's our main tool to relax the muscles around the breathing tubes, and and steroids as an inflammatory agent to shrink the swelling. This is just a little picture of your normal airway being nice and big, and then if you're starting to have an asthma exacerbation, the muscles constrict, pinching it from the outside. The lining of the breathing tube swells up on the inside. So just to get briefly at some of what we have for patients with airway reactivity, it comes down to medicines designed to relax the muscles around the breathing tubes. Those are called bronchodilators, usually albuterol. Medicines designed to decrease the irritability, or the tendency to have this happen. So those are variations on steroids that are inhaled so that they coat the airway. They don't work quickly, but over time, the lungs can become less reactive. Combination medicines that people take every day. And then when things aren't going well, steroids by mouth, which can have a much greater effect on the inflammation in there. And then just thought I'd bring this up. You hear lots of different opinions about the best way to give medicine into a child's lungs. And the two major things for small children are either the nebulizer, this machine that makes a fog that you breathe medicine in, or the inhaler, usually attached to a tube that either you call a valve holding chamber or a spacer, depending on how pedantic you are. And the inhaler gets puffed in the air and the child breathes out of it. And what I wanted to just say about this is that these two are, for all intents and purposes, equally effective. There are some children whose families tell me that the nebulizer works better for their kid, and I don't argue with them, and I'm happy to work with them on that. There are just as many, if not more, that tell me that the inhaler is more effective for their child, and I'm happy to work with that. But, and in pediatrics, you always need plan B or plan C. So when the child begins to reject this, you have this. When they reject this, you can go back to that. But the main advantage of the inhaler is it's portable and it's fast. And if you have a child with a medical complexity and your life is pretty busy, I think speed is, and convenience is the wrong word, because that implies that it's frivolous. I think it can be really important to be able to get the medicines easily. And then all I have less to talk about, before I overstay my welcome, is airway clearance. A lot of our children with medical complexity have trouble with a poorly coordinated cough or a cough that can be weak. This puts them at risk for recurrent pneumonia and other problems. Some children have secretions that are unusually sticky as well. And that's what our airway clearance techniques are about. This is actually could be a whole hour. But there are two main devices that we could consider using. One is called the Cough Assist, which really functions like the old shop vac in my dad's wood shop, which was basically there's a compressor attached to a mask, and it gives you a positive pressure to stretch your lungs, and then it flips to suction and helps you suck mucus out of the lungs that the child couldn't do on his own. And then the other thing that is quite commonly used is the vibrating therapy vest. There's a lot of brands of this now, and they all have the same idea, which is this vest that this child is enjoying wearing. It inflates with air, and then it vibrates at different frequencies designed to loosen the secretions from the deep part of the lung so that it moves into the center, and then you can cough it up on its own. And I think that's pretty much all I prepared to say. And this when we're all done, I'm happy to answer questions as long as anybody has. So
thank you so much, Dr. Needleman. Really appreciate
absolutely.
that. Yeah, I'm gonna hand it over to Laura now. Go ahead, Laura.
Thank you so much. That was a great introduction to some of what I plan to share. So as Sarah mentioned, my son Alex has Bourne-Joubert syndrome. He's currently 13 years old. And the first few years of his life, we had many of the viruses that were mentioned, like RSV, bronchiolitis, etc. We were in the hospital every 3 months trying to deal with these issues. And so what I'm going to share today is a combination of work that we've done with our pulmonologists, PT and adaptive equipment, and then some things that we've done from a home perspective that have helped keep him out of the hospital, for knock on wood, over the last decade. So I think I completely agree, prevention is the way to go. So for us, in terms of working with the pulmonologist, so we used a device called an IPV, and it has a similar function. It's a percussive ventilator as the vest that was just described, and that it pulsates the air, so it breaks up that mucus that was like in the tubes that you saw, and then partner to that with the cough assist to extract that mucus, right? And so for us, we found that the inhaled steroids, budesonide specifically, worked well. So for Alex, he had a lot of neuromuscular issues. When he was younger, he was spending a lot of time laying flat. He didn't really have a lot of strength. And so getting that pulsated air really helped to break up the mucus in a more targeted way versus the oral steroids that are more systematic to the body. And complementary to that, we would do saline nebulizers every 2 hours. So saline is just like a salt water. You can get a script for that in these capsules that you put into the nebulizer. And we would use that, especially if he started to have any kind of like croupy, like seal-like cough. On a regular basis, even when he was not sick, which we still do today, is we do a nebulizer twice a day as part of our preventative regimen, to ensure that, we're just clearing out any kind of congestion or mucus that can be there. Another thing that we did with our recommended by our pulmonologist was chest PT. So you can see these suctions here. You can also just use your hands. And if you go to the Cystic Fibrosis Foundation website, there's some information, and we can share the links after this, that can tell you. And it's sort of like a series of different kind of movements that you can make on the chest, again, to help like clear out some of that mucus. Complementary to that, there's a device called a Yankauer suction, and that can again clear some of the mucus from after you're doing this chest PT exercises. So we found those effective to be really helpful from like a respiratory prevention perspective. I mentioned that neuromuscular strength also has a big impact, right, on your breathing. So we're talking about like your chest and your core body, right? And so once Alex got equipment to be in a stander, to be in a proper wheelchair, and like upright positioning he could tolerate being in an upright position for longer periods of time, that also helped versus laying down, where it made it harder for him to breathe, right? And I would say over the years, as we've done like intensive therapies, like at the Napa Center or outpatient and school PT, continuing to build that strength of your upper body and core has been really critical, I think, to helping. So I think that's another like long-term preventative strategy for families, is like continuing to build that strength, getting the equipment and things that you need. And then, from a home perspective, so Alex has a G tube. So we also around this time try to give him a lot of fluids, Pedialyte, coconut water, like things with electrolytes to really help also flush out any kind of viruses. If your kids can tolerate more oral things by mouth, that's helpful. Having a humidifier on during the season, also with the air, or like ceiling fans. We'll do like aromatherapy with eucalyptus, can also be helpful sometimes, and like kind of clearing out your sinuses, or even like a hot shower, just to like, have that respiratory clearance. And then finally, you may also find there's some underlying challenges in terms of breathing. So, talking with your pulmonologist to see, like, does it make sense to have a sleep study? Do you have like central or obstructive sleep apnea? Are there other things that potentially are causing risk? And then, finally, to the point about, interactions, I think sometimes we'll try to reduce the amount of interactions that we have and places we go and things that we do just to reduce our risk. We'll take supplements like turmeric immune from like a preventative perspective as well to kind of reduce inflammation, and getting lots of sleep. I always say like sleep and fluids are some of the most important things, which I know sleep can be really challenging for our kids, but that also is really critical from a prevention standpoint. So those are some of our strategies. I think, I mean, the other thing, a couple other medications I would say that have been helpful for us too preventively is like Claritin and Flonase, in terms of like some of the sinuses and things too. But yeah, but water and sleep are I'd say most important. So,
Awesome. Thank you so much, Laura. That was super helpful and just so good to have like a parent's perspective too, and your years of experience is so helpful.
It's quite an achievement to stay out of the hospital for 10 years, right? So that in itself, like, speaks huge for the hard work you're doing. If you don't mind if I ask a question,
sure, please.
one of the issues that I often have is with getting equipment for children whose diagnosis doesn't fit into the boxes that they have at the insurance company, right? Which you guys, your children do not have a box at the insurance company, right, that they can check off. So like getting an IPV or getting other types of equipment, have you had a lot of issue with that? Does your organization give some advocacy on that for families?
So this was before I think I started the foundation. But,
Okay.
I would say our pulmonologist had to jump through a lot of hurdles and a lot of justifications, even because his experience was with the Duchenne's population at Cincinnati Children's, and showing that this has been an effective process. And so there's even challenges in terms of the publications and evidence base that the insurance will accept for this. But eventually it did get approved, but it was not an easy process.
Yeah, I fear that the process only gets harder year after year. But
Yes,
when you have a rare condition, then like you run into more roadblocks, I think.
absolutely.
Yeah. Is there anybody else who would like to ask any questions or share their experiences?
I have a question. So I have a quick clarifying question for Laura and then a question for Dr. Needleman. So Laura, you mentioned that Alex is on the preventative nebulizer 2 times a day. Is that just with saline?
Just with saline. So what we'll do is our daily regimen is saline twice a day. And then if we notice that he's starting to have any kind of like croupy cough or there's something respiratory, we'll do budesonide twice a day and then saline every 2 hours.
Thank you. And then for Dr. Needleman, a lot of families, their child with an ASXL-related disorder is not their only child. So what's your suggestion if you've got a sibling or someone else in the household who comes home sick and you're trying to protect your kiddo who's more medically complex? What are some sort of practical suggestions you might offer to the family?
Yeah, that's certainly a huge issue in New York City where people have pretty small spaces. And and I don't have anything great to say. Again, hand washing. If you, depending on the age of the child and your living space, you may be able to create some space. You may be able to ask an older child to wear a mask in the living room if they're watching a movie together or something. If the children are sharing a bedroom, which is really common, I think you got to try everything. I think by the time one person has overt symptoms, the virus has been in that room for several days already. It's a great question. I wish I had more to say. I wish we had more than just influenza vaccination, but one child is my patient, but I really try hard to get them to vaccinate the whole family to decrease the amount of spread there.
I was just gonna share a little bit of my experience with Sammy, who has Shashipania. We've never had to use a vest or a nebulizer. But for him specifically, it seems like every respiratory virus that he has will turn into croup. And when I first heard his cough, it was like such a really terrifying sound, and it happened right in the middle of the night. And I feel like croup obviously can happen to anyone, but for Sammy, it was like every single cold was him being unable to breathe, and a middle of the night wake up that ended us in the ER multiple times. And a lot of times we would be admitted because despite like the epinephrine that they were giving him, he couldn't recover, and it would take a day or two sometimes for that airway to open back up again. So I feel like that's definitely worth mentioning, because I know a lot of Shashpania families, their kids have tracheal Malaysia or laryngomalacia, which is like what was explained to me is just that it's like a flappy airway. Like there's just not like it's just anatomically different.
Softer, yeah, more
Yes.
collapsible.
Yeah, thank you. And so what would make, like a typical person have maybe a raspy voice, for Sammy, it just shuts down, and his cough is like, it sounds like a seal barking, and it like he would be fine, like maybe have a little bit of a runny nose when he goes to bed, and then wake up in the night and he's gasping for air. He's putting his chin up like this, and you can see like as he's sucking in, like breathing so hard that you can see like his skin dipping in around like under his rib cage, blue lips, and it just was terrifying. So the things that we have put in place preventatively, if someone in our house has a cold, Sammy thankfully has his own room, so that is a blessing for us. But we keep a humidifier running, like Laura was saying, like having the room have really moist air helps kind of prevent it getting to a bad place. And then if he was having any respiratory symptoms, we actually would give him Motrin as a preventative to kind of keep that inflammation down. So those are some things that we've done, and I know a lot of other Shashipania families have just mentioned croup as a continuous thing, and Sammy had all the imaging done, like the tube down the throat. I can't remember what it's called. Like
Bronchoscopy.
yeah, to try and figure out if there's anything surgically that can be done, but really it's just like how he is anatomically, and they're not able to do any kind of surgery. And from what I understand, like typically kids will outgrow that by the age of 5. And Sam's 9, and he still will struggle with croup. But thankfully, we don't end up in the ER now. It's just more like a yucky night of no one getting sleep, but he's not turning blue or gray. So he is outgrowing it. So I just wanted to share my experience and open it up again. Like if this has prompted any questions that anyone has, or just, I feel like there's a lot of wealth of knowledge, people just sharing their experience, and someone watching this recording down the line can maybe gain some knowledge from your experience. So if anyone would like to share.
If I could respond to what you said, it's most respiratory problems get worse in the middle of the night. So waking up at 3 o'clock in the morning with your child not being able to breathe is so common. That's because your body's natural steroid levels fall after like midnight, and so, but it makes it just triply terrifying, I think. But I guess one of the most important things, like, is what you're doing is, as you identify your own child's pattern, then you can sort of establish your sort of individualized protocol. I have some families that keep oral steroids in the house that the kid might not be sick enough at 10 p.m. that any ER would give it to them, but they know what it's going to look like tomorrow because they've been there. And I said, well, we're not going to go to the ER because you're not going to have to argue with them. You're going to have it. And usually I ask them to call me so I know what's going on. But I don't think I've ever disagreed with a family with an experienced track record, knowing that there was time to do that. And that's what you're doing with Sammy, is seeing the individual things that the rest of us wouldn't be able to see without you there to show it to us.
Yeah.
And then one thing about humidifiers, which I know can make people a lot more comfortable, you do have to really be sure that there isn't any mold growing in there. I'm always concerned about mold in the humidifier. Then you've got a system for putting it in the air in your room, which might not be.
Absolutely.
Yeah.
Yeah, I should have mentioned that too. When we are running the humidifier, we clean it every single day to prevent that, because that is, you just don't want to multiply your risk and make
Yeah.
everything worse as you're trying to make it better. Yeah. Jamie, did you want to share?
I did. I had something to say. So we were incredibly fortunate to walk into Dr. Needleman's office like 6 years ago, and with Asher, and he sat down and said, boring opiate syndrome. I've never heard that before. I will look it up after this, I walk out the door, but why don't you tell me what that means for Asher? And that meant so much that we had a doctor that, that we had a doctor that walked in the room and was just willing to listen. So we've been super fortunate to have Dr. Needleman in Asher's life for a long time. And I think for us, it's one of the things that has helped us is knowing that we have a really fantastic team that surrounds him, and knowing that, like Dr. Needleman said, he responds immediately. If we have a concern or a question or anything, he responds and trusts that we understand what's going on with our kid. And I think we run into a lot of specialists that don't trust you as a parent, and we're living it 24/7, and that expertise is worth more than a lot of people, I think, realize. But I do actually have a question, Dr. Needleman. So when all of these preventative things unfortunately fail and we find ourselves in the ER and we find ourselves admitted, do you have any advice for coordination of care with other providers in the hospital, and how we would what's the best way to sort of deal with that?
Yeah, it's probably easier in other cities where there's one major children's medical center than where we live and work. It seems like communication between the specialists is so much worse these days than it used to be, even though you would think with all of this extra technology it'd be better. So I would like to apologize for that. I'm sure some of that is my fault somehow. But I think we all agree that it's important. And some families really can help, really facilitate that by basically, giving me the number and reminding me to call. It is super important for in our situation, right? You guys often get admitted to a different hospital than where I work. I can't look at the records. If you get an X-ray anywhere, leave with a disc. No matter what they say about it'll be online, we'll fax it to your doctor. leave with a disc. And so that there, you know, and it maybe someone will have, your doctor will have a disk drive. You can look at the X-ray. I bought some disk drives for the office so that we could look at X-rays from other hospitals. All this technology doesn't work as well, and people are much more distracted by it. So I think if you're not in a situation where all of your care is in one silo, you know, keeping records of yourself, of your tests, don't get records sent to, if you're going to get like a second opinion, don't get the records sent there, get it sent to you, make a copy, and then send those records there. You guys probably all had experiences with stuff like this, so probably not telling you something you don't know. Yeah. But I agree, it's a big issue.
Yeah, I do think that is beneficial information to share, especially for families who are maybe newly diagnosed and haven't gone through the first rodeo of the terrifying ER trip. I know, like when Sammy was little, it took me a while to find my voice and to realize that the knowledge that I have the doctorate in Sammy. And, you know, while we may be seeing a respiratory therapist or pulmonologist or the ER doctor, I'm the one who knows Sam best. And so I think giving parents the permission, the confidence to be able to speak up and say, no, that's not going to work. My kid's different, you know, and to be the educator to the doctors, obviously in a respectful way. And I think Dr. Needleman, it sounds like your heart and your spirit is like a continuous learner, which is such a gift to families because not every doctor is that way. You know, there's some doctors who kind of think that their say is the end all be all and don't always listen. So
Well, I'm sure that's true, but I do think that a lot of people do appreciate when the family members come armed with information.
Yeah.
And people are often, I know in my, so, you know, my family, there were some doctors, but in my wife's family, there weren't. And there often was this concern over there about offending somebody or something. No, I think actually meeting a strong advocate for a medically complex individual is refreshing for most of us and rewarding. So just keep doing it.
Yeah. Amanda, do you want to say something?
Yeah, and I'm happy to defer to others if others have questions, but in the absence of other questions, so my question is along the lines of this advocacy piece and thinking about newly diagnosed families, as you said, Sarah, who may be new to this. So maybe this is a question to start with Dr. Needleman, and maybe some of the other seasoned parents have thoughts on this as well. What would you say is the threshold for pursuing care for your child if they are showing signs of having some sort of respiratory virus, and how might that be different than what advice you'd give to a neurotypical or typically developing child? Is there a difference in that threshold for calling the pediatrician or going to the ER or not? I'm just curious your take on that.
Well, first of all, no one should ever lie awake in bed wondering if there's a problem that you're not addressing, right? You know, if you're there saying that cough doesn't sound right, you know, like don't, you know, you're probably right. And you know, I always struggle with anytime I give like a list of criteria, you know, for any patients, we're going to do this, we're going to do this. If this happens, we're going to do that. You know, just like, you know, in tennis, the ball sometimes falls on the line, and anytime I give criteria, the patient something will happen in between. Anytime you feel like something is wrong, you know, you need to listen to that. you know, what's the worst thing that could happen? The worst thing that can happen is you lose a few hours of sleep and come home, you know, and everybody is okay. So,
I mean, and one thing I wanted to add and sort of also build on what Sarah talked about earlier is that I agree. I think these type of viruses impact our children differently, and that like like cough, I think their airways are smaller, like you said, more restricted. And so it will, like, it is very unnerving when you hear that for the first time. And so I do think I would recommend to be seen sooner. And I do think it's important to be, proactively impacting these strategies, because it also, like you said, takes a lot longer to recover. Sometimes it would take Alex a week in the hospital, and he would just be sleeping constantly and on all kinds of fluids and things, because it just took him more time to recover and get through all of that. So, but yeah, I mean, I think sharing your experience, sharing some of this information is helpful for people to know, because often you go to the hospital and they've never seen a child like yours, and they don't really know what to expect or how to manage it. And they're obviously doing the best that they can with the existing protocols that they have in place. But it's not always the same.
even if they have seen 2 children with your child's diagnosis,
Yeah.
I've seen 10,000 kids with asthma, and many of them are very different from each other. But I have a really good sense of the wide range of variety, because I may not even, it may be more than 10. I mean, I've been around a little bit. So, but if there's that kind of variety in a common disease, isn't there likely to be that kind of variety in uncommon disease, right? So just because the 5 that you saw in your, in your past 10 years, did X, doesn't mean that the 6th one is going to do the same thing. It's somehow easier to see that variety in common diseases than in uncommon ones, but it has to be there the same way.
I'd like to add a little something to that also with Asher in particular. One of the things that we have noticed is he doesn't tend to present with a fever in a situation where most kids would present with a fever, and that would be a good indicator that they were sick or getting sick or really sick. And he has a really high tolerance for pain. So by the time we know something's wrong, something's usually really wrong. So we've had to learn to read different cues from him to sort of give us a gauge for how does he feel, where is he. In January, he got admitted to the hospital, and we were admitted for 9 days, and the ENT resident didn't want to admit him because she said it was just that he had too much wax in his ears. And we said, no, he's in a lot of pain, and we know he's in a lot of pain. Well, he doesn't have a fever. I understand he doesn't have a fever, but I'm telling you, this kid is sick. So these kids just don't tend to present typically, and that makes it tricky for having a conversation sometimes, especially when you're in an ER situation and you're not talking to providers that know you and know your kids.
Yeah.
100%.
Yeah, absolutely. And I think that, just reiterates the fact of kind of like what Dr. Needleman was saying, like if you feel like something's wrong, then listen to your gut. And I have been guilty of hesitating to go to the ER because I don't want to get there and look like I'm overreacting or I'm a hysterical mother or something. And I have been treated like a hysterical mother before. And
Well, that's unfortunate. I'm sorry. But that could be the worst thing. Like,
exactly. Yes. Go
know.
ahead and think I'm crazy, but I'm going to stand here and demand things anyways, and I think it, kind of going back to what I said before of just like finding your voice and being the advocate, because you are the one who knows your child best, kind of like what Jamie is saying too. Yeah.
Another thing I was going to suggest as like a way to kind of monitor is you can get like a pulse ox monitor. You can probably order this online, like relatively inexpensive. You can just put your child's finger in it, and that could just be like another data point for
Mhm.
you too. I think so the more you can try to explain to the providers, like, this is the situation, these are the things we're observing, like, this is what we know, that can help in terms of your advocacy.
If I could say something about
Yeah.
that.
Yeah.
A couple things. It is possible if your oxygen level is low, then that is an important sign that you need more care, and in that regards, the pulse ox can help you. And we use pulse oximetry for a long time, and then the inexpensive pulse oximeters just became available in the past 4 or 5 years that people are now able to have them. What I learned a couple years ago was that when they bring one of those, like, buy at the drugstore pulse oximeters to the market, they only have to test it on 15 people. So yeah, right, like, and so a lot of them may not be that accurate, and that was very disturbing to find out. And I think not a lot of them they're not all calibrated for young children, and then even if they were, you can have a fair amount of respiratory disease and still have a normal, of some types of respiratory disease and still have a normal saturation. So Laura, I'm not arguing with you. Everything you said is right. But if your child looks sick to you and the pulse ox says 100%, go with your child may still be very sick, right? And so, like, it can help you if it can help you if it's low. Some children may not look distressed and their oxygen level may be low, but if your other methods indicate that things are not right, then you should lean on that. So there's some things in the chat. Is somebody monitoring that?
Yeah.
Yeah, I'll follow up with Megan. Yeah.
Okay, sorry about that. I want to be respectful of our time. We're coming to the end of our hour here. And Dr. Needleman, I just thank you so much for your time. I just appreciate your knowledge and expertise and just being willing to donate your time to us. And it's just so helpful. Appreciate you so
Well,
much.
thank you for inviting me, and I really appreciated hearing a little bit about your group, which I think you've done a lot already in a short period of time. And like I said, there's been a lot of progress in various rare diseases pushed by families and groups like this. So that's wonderful. Good for you guys.
Yeah, thank you so much. Appreciate it. All right. I'm going to end the call now and just thank everybody for participating today.
All right.
Bye-bye.
Thank you.
Thank you, everybody.